Before assessing a wound, review the patient's chart to determine the wound's location, size, and whether it's open or closed with sutures, staples, or steri-strips. Also recall the basic types of wound healing to determine which type is present. In wound healing by primary intention, tissue loss is minimal, the wound's edges are pulled together and closely approximated, and healing occurs by connective tissue deposition, as in a surgical wound. In wound healing by secondary intention, tissue loss is greater, the wound's edges are not approximated, and healing occurs by granulation tissue formation and wound edge contraction, as in a severe laceration or pressure ulcer. Wound healing by tertiary intention occurs when surgical wounds are not closed but left open for 3 to 5 days, allowing the edema or infection to diminish. The wound edges are then sutured or stapled closed. If the patient's initial surgical dressing is still in place, perform an indirect assessment. To do this, inspect the skin around the dressing for any swelling, redness, bruising, or other discoloration. After performing hand hygiene and applying clean gloves, palpate around the dressing to assess the skin temperature and detect any pain or swelling. Also check the outer surface of the dressing for moisture, drainage, and bleeding. If you detect a complication, such as frank bleeding, notify the physician at once. When removing a taped dressing, be sure to support the surrounding skin as the tape is being removed, and remove the tape in the direction toward the wound to avoid pulling on the wound edges. After removing the initial surgical dressing as ordered, perform a direct assessment. First, inspect the dressing, noting whether it's dry and clean or shows signs of bleeding or drainage. If a suture line exists, inspect that next. Normally, it may have clean, well-approximated edges, possibly with crusts from wound drainage, inflamed, swollen outer edges for the first 2 to 3 days only, and bruised-looking skin around the suture line. Now assess for any odor and describe the wound color, which represents the balance between necrotic tissue and new scar tissue. Black wounds represent full-thickness tissue destruction, as in necrotic or desiccated tissue. Yellow wounds represent the death of subcutaneous fat tissue and muscle degeneration, as in necrotic slough and purulent drainage. Red wounds represent increased red or pink granulation tissue. Then palpate the wound edges. Note areas of localized tenderness or drainage. If you detect any drainage, note its color, consistency, and amount, which can be expressed as the percentage of the dressing saturated or the quantity of drainage, such as scant, moderate, or copious. If indicated, collect a specimen of the drainage, as shown in the video skill, Collecting a Specimen for Wound Culture. Measure the length and width of the patient's wound. Be sure to measure at the widest and longest points of the wound, using a disposable measuring tape. If the wound is oddly shaped, make a drawing or take a photograph of it. Rotate the swab along the wound's edges to determine if there are tunnels or deeper areas in the wound. Then, if appropriate, measure the wound's depth with a sterile applicator swab and convert that depth to centimeters. When you have completed your assessments, redress the wound.
Okay, just about done.
As part of your follow-up care, regularly document the patient's temperature and direct wound assessment findings.